Okay, and then I will talk about lesion detection with LCI and short DBE for colonic ESD. So this is the LXL, and this is the LCI and BLI. And using LCI, we use 410 nanometer wavelengths. This is RGB, red, green, blue, in addition to 3 colors. We use 410 nanometer wavelengths light. And it can penetrate only for a short distance from the mucosal surface. So in the neoplastic lesion, there are microvasculature at the very surface, very shallow, close to the surface. So this 410 nanometer wavelength light reach the blood here. So the hemoglobin absorbed this light, but surrounding area, the vessels are deeper. So this violet light does not reach there. So it comes back. So by that difference, we can make the difference between this is the gastric lesion. This is the white light. We cannot see the gastric cancer, but changing to LCI, and we can see this area a little bit red, rather compared to the surrounding purple. This is a bit red. So we recognize that red area and change to the BLI and come closer and magnify this area. And then this area has a irregular microvascular pattern. So there is the irregular microvascular pattern here. So clear demarcation between the surrounding mucosa, and this is the typical finding of early gastric cancer. So this kind of early gastric cancer cannot be detected with the standard white light image. Can you see the irregular microvascular pattern? Totally different from the surrounding mucosa. You see? It's different. So this is how we find the early gastric cancer using LCI. This is a bit reddish area. So red or orange in purple, that is how we find the early gastric cancer. Orange in the purple. Same here. This is white light. You can't see the gastric region. Oh, here is the orange area. Once more. Turning to LCI, then it becomes orange. Now you can see this is the cancer. Okay? So next. How about next one? Can you see a cancer here? It's difficult to detect, but change to LCI, purple and orange. So the orange surrounded the purple is gastric cancer. And the same in the colon. This is the white light image. The color tone is the same, but using LCI, surrounding mucosa becomes purple because of the deep vasculature, and the neoplastic mucosa becomes orange because of the shallow vasculature. And after detecting neoplastic area, change to BLI and magnify and make sure this is a neoplastic lesion. And what is this? This is AI. Even AI can find the lesion easier with LCI. Combination of LCI and AI is the best way to detect and characterize the neoplastic lesions. So this is the adenomatous polyp, then just called snare polypectomy. So nowadays we can use LCI and AI, so much easier to detect and characterize neoplastic lesions like this. Okay, so this is the Fujifilm LCI and BLI and AI. LCI is good for early detection and BLI is good for characterization with magnification. And short double balloon endoscope. This is good for Roux-en-Y anastomosis and doing biliary examination. This is an example of living donor liver transplantation. So I did balloon dilation for the anastomotic stricture. So the short double balloon endoscope is very good for the ERCP in patients with altered anatomy. But what I want to tell you is for the colon. This is also good for difficult colon, even with adhesion. This patient had an adhesion between the transverse colon and the ascending colon. So the hepatic flexure cannot be straightened. But as long as the overtube balloon grips and the flexible endoscope can turn the hepatic flexure and reach the cecum. So the double balloon endoscope is also a good tool to overcome a difficult colon. But my main topic is stabilization with the double balloon endoscope. And then I want to show you this video. This is an ESD. And can I use the volume sound as well? Recently, I use underwater technique. And actually, this is not water, this is saline. Saline perfusion. I use continuous saline perfusion, and currently available short double balloon endoscope doesn't have a water jet channel yet. So I infused the saline through the flash knife. And continuous infusion of the saline through the flash knife. And this is an end cut of the mucosa. And cutting the distal side of the mucosa, and then I create a pocket, submucosal pocket. So in the saline, endoscopic view is very clear, and even in the saline, I can use the electricity. And even if there are some bleeding, the blood can be washed away from by the flow from the flash knife, and the drainage of the saline is through the overtube of the double balloon endoscope. So just one-way flow. The bleeding or bubble formation makes the ESD procedure difficult. But as long as you don't use suction, it just go away. So I connected the suction tube to the over tube, like I showed in this today's demonstration. So this is the suction. So the saline is sucked away through the over tube. So the infusion is from the knife and drained through the over tube. So just one way. So it is easy to keep a good, clear endoscopic view, and a little bit of bleeding or a bubble created by the electricity goes away. Doesn't interfere with the endoscopic view. So as long as the endoscopic view is clear, we can see the blood vessel clearly, and we can see through the muscle layer. And in the submucosal pocket, the endoscopic control is very stable, so the dissection is easy. So this side is the muscle layer. We can see through the muscle layer and leaving a little bit of submucosal tissue on the muscle side and dissect. And now I completed the pocket. So I made the pocket like this. This is the muscle, and this is the other side of the pocket. So the only both sides remains now. And in the water, in the saline, the specimen floats. So it's easy to cut the mucosa, remaining mucosa, and even if I cut this side completely, but still I can have a good view, good operating field on the other side. If that in the gas, it collapses, but in the saline, it floats. No sound. Really? Should work. Anyway, so I was explaining how to go outside of the pocket. Yeah, estimate the outlet of the pocket and goes up to the mucosal side and go out of the pocket. That's what I was explaining. Anyway, cutting the right side. Maybe sound is no. It's okay. So in the water, even without traction, the specimen floats. So it is possible to continue the incision and dissection, having enough space for the procedure, and cut and finish the procedure. This is the last cut. Okay, that's it. So the short double balloon endoscope is good for colonic ESD. One is because it can stabilize the endoscopic control, and it can be used for the drainage. And please come to the JGS International. Okay. Thank you. Conclusion. LCI is useful tool for early detection, and LCI should be used from the beginning of observation. And double barrel endoscope is useful for ERCP in altered anatomy, and it is also useful for continuous saline perfusion in pocket creation method of ESD. Thank you for your attention.